Good evening and welcome to all the delegates and respected speakers for this extensive session on manual small incision cataract surgery from the International Society of Manual Small Incision Cataract Surgeon Society. At the outset, I would like to thank the Scientific Committee Chairman, Dr. Elan Kumar, and the Karnataka Ophthalmic Society for giving us an opportunities in this conference. I want to thank my friend Dr. Gyaneshwar for patiently coordinating the topics with the speakers, along with Dr. Deepak Megur, who is a master teacher and surgeon who needs no introduction, and giving us a very high quality session, which we are going to see in a couple of minutes. So what we have with us today is 3 sessions of 1 hour duration covering the basics, complications, and advances respectively. Each presentation is of 6 minutes duration, followed by 20 minutes discussion at the end of every session. I welcome Dr. M.S. Ravindra sir, who is the director of Karthik Netralia, who is a great master and a father figure for SICS. And along with another stalwart, Dr. Mallikarjun Heralgi, who will co-chair the session, who is the head of the Cornea Department, Shankara Eye Center, Shimoga. He is a fine teacher for younger generation. And I also welcome Dr. Sundaram Shetty sir, who is the chairman of our ISMSICS Karnataka chapter, to chair the session along with Dr. M.S. sir and Dr. Hiralgi sir. And we will start the session with first, which is going to be the basics of MSS, manual small incision cataract surgery. And we have the first topic, which is anesthesia, peribulbar, parabulbar, or topical, by Dr. Sheetal Saur. Over to the presentation. Dr. Sheetal Saur is an additional professor, Department of Ophthalmology, Yanapoya Medical College, and she's a member of ISMSIS Karnataka chapter. Over to you, ma'am.
So I was told the recording will be played.
Yeah. I think I'm waiting for the
person to. Yes, ma'am. I'm playing the recording now.
Yeah.
Thanks, Dr. Devaprasad. We should thank KOS for giving a prime time on the first day itself in the evening for the most important MSICS program. I'm grateful to the president and all the office bearers and Dr. Elan Kumar, the scientific committee chairman, for giving this privilege. 3 hours today is going to be a festival of SICS. You will see all kinds of SICS. You can start, Karthik. I'm just filling up the gap. We'll see all kinds of SICS, and if somebody wants to learn SICS, this is the program.
And everybody. Very good evening to everybody. I'm Dr. Sheetal, and I'll be starting today's session with basics of ophthalmic anesthesia. At the end of this session, you would be able to understand the rationale of various blocks, its principal techniques and complications. You'd be able to describe the merits and demerits of each of these types. The ideal anesthetic is the one that is totally risk-free for the patient, that guarantees comfort throughout the procedure and also gives perfect operating conditions for the surgeon. One must remember that the sensory supply to the eye and the adnexa is via the trigeminal nerve through its 3 divisions, the ophthalmic, maxillary, and the mandibular. Blocking the motor supply causes akinesia. So the extraocular muscles and the levator palpebrae superioris are supplied by the 3rd nerve, 4th nerve, and the 6th nerve. The orbicularis oculi muscle is supplied by the 7th nerve. It's important to remember that the anteroposterior diameter of the globe is 24 millimeters, and the risk of perforation increases with increasing axial length. One must also remember that the optic nerve runs a sinusoidal course in the orbit and is quite long. This is the vascular supply, and in the superotemporal quadrant, you can see it is the most vascular. So these are the different anatomical spaces that are relevant to this topic. This is the retrobulbar space within the recti muscle and the intermuscular septa that connects them. Outside of it is the peribulbar space. Peripherally is the subperiosteal space, and surrounding the globe is the subtenon space. These are the different types of blocks that are used commonly. This is topical anesthesia, intracameral, into the anterior chamber, then the subconjunctival injection, subtenance injection, retrobulbar, and the peribulbar. Before giving any infiltration block, remember to monitor the baseline, pulse, blood pressure, and respiratory rate. If you have a pulse oximeter, it's always good. Make sure your resuscitation equipment is functioning before you give a block. Ask the patient to look straight ahead, and before injecting the drug, withdraw the plunger of the needle to make sure there is no blood. So the drugs that are commonly used are 2% xylocaine with or without adrenaline. Adrenaline in the concentration of 1 in 1 lakh. So the duration of action of xylocaine is for about an hour, and adrenaline prolongs the duration of action of the drug and also reduces the systemic side effects by delaying its absorption. Again, 0.5% is used when you expect the surgery to go on for a longer time, 3 to 4 hours. And the injection hyaluronidase is mixed with lignocaine or bupivacaine. That is 50 to 75 international units per ml. And this drug helps to diffuse the local anesthetic. Topically, we use proparacaine very commonly, and intracamerally, preservative-free 1% xylocaine is used. Xylocaine gel may also be used for surface anesthesia. So the technique of retrobulbar block, you can give this through the conjunctiva or through the skin. At the junction of the lateral 1/3 and medial 2/3, you advance the needle parallel to the globe, and then you direct it upwards and nasally. You will find two resistance. One is the orbital septum, and second is the intermuscular septum when it reaches inside of the cone. How do you know you've reached the retrobulbar space? You will find that there's some amount of drooping, dilatation of the pupil, and a little bit of proptosis. Remember to massage the eye a little bit after giving the block. Now, peribulbar block may be given at two sides. Mostly we give it inferiorly, but you could also give a superior block. Here, more drug is required. 6 to 10 ml, contrary to the retrobulbar injection where we hardly give only 2 to 4 ml, where the action is immediate, whereas here it takes from 10 to 20 minutes for the drug to act. Again, the injection site is similar at the junction of medial 2/3 and lateral 1/3. What you need to remember here is the direction of the needle. It's parallel to the floor initially, and then you have to turn the direction laterally, that is away from the globe. You can give it in 3 shots, that is inject some amount behind the orbicularis, some amount anterior to the equator, and the rest of it behind the globe. Now this is the superior block, not very commonly given. Here the needle is directed backwards and medially. Now this is a very vascular quadrant, so the chances of complication are more, including causing trauma to the optic nerve. So you can see this being
Dr. Sheetal,
given.
may I interfere for a minute?
Of course, if you're skilled and you have enough practice,
Karthik,
you will not
we are
get
not seeing the video. We are
complications
seeing
with
only.
stop the video. So this is the subtenance block. I think it's it has a wonderful mix of infiltration as well as topical anesthesia, because the advantage is the drug easily moves into the retrobulbar space. Hence, the action is almost instantaneous. You hardly require 2 ml of the drug, and it gives very good anesthesia and akinesia. What you need to do is ask the patient to look up and out, and in the inferonasal quadrant, give a small nick, dissect right up to the posterior extent of the globe. Then use a special needle, a Stevens needle or a 19 gauge cannula. Advance it till the hub of the needle and inject around 2 cc's into this space. The main complication of this is just phimosis and a bit of subconjunctival hemorrhage. So you see the drug here reaching the retrobulbar space. This is the drug that is being injected after dissection of the conjunctiva and the subtenance space. Now, topical anesthesia is wonderful in the sense there is no risk of globe perforation, injury to the optic nerve, also life-threatening complications like cardiorespiratory depression or convulsions, which happens typically with retrobulbar anesthesia or sometimes peribulbar anesthesia, is not there. There is no needle prick here. Post-surgery, the visual recovery is very fast, and also there is absence of any increase in the orbital volume and the associated complications. One must remember that there is no akinesia here, hence use it very cautiously for large incisions. And remember, the pain here is experienced only when there is stretching of the eyeball, primarily the area of the ciliary body. So the complications of infiltration anesthesia is primarily chemosis and ecchymosis. Rarely we may get retrobulbar hemorrhage. You can see the two types, this one causing compartment syndrome, and this is a more diffuse type.
We are not sharing the PPT. The only video was in the drive.
How do we identify retrobulbar hemorrhage? There is painful proptosis, eyeball is very tense, there's a subconjunctival hemorrhage and chemosis, and also the visual acuity decreases. So what RBH does is it reduces the vascular perfusion and causes ischemia of the optic nerve and retina.
Dr. Sheetal?
Yeah, Karthik, my PPT is not seen in that.
Ma'am, in drive, the video which was only uploaded, there is no PPT in the drive.
Is it? But I followed the instructions given in that video. And I remember checking it.
No, ma'am, in the Google Drive, no, ma'am, in the Google Drive, there is only the video. Yes. Yeah, okay. The video was only uploaded. There is no PPT in the drive.
Okay, I have. Should I share it here?
You can share, ma'am. I will give the option to share the screen.
Should I continue?
Yeah, you can take just 3 minutes and finish off the presentation. Just 3 minutes.
Okay. I'll just quickly run through this.
Yeah.
So these are the images. I'll just run through it quickly, showing the rich vascular supply of the orbit. And I wanted to show the spaces of the orbit because they become very relevant here. Then these are the preliminaries that I mentioned that must be done for all blocks. These are the drugs to be used commonly. And this is the retrobulbar technique. And remember, we get two resistance here, one at the level of the orbital septum and then within the cone. So what one needs to look for is the drooping of the upper lid, the dilatation of the pupil, and mild proptosis, and you know you're in the retrobulbar space. In good hands, really, you don't get too much of a complication. And earlier, very long needles were used, but now 23 gauge needle, 24 mm in length does suffice for this. Yeah, so this is the technique of peribulbar. This is the inferior block that is given. Now, what one has to remember is you need to be parallel to the floor and then direct the needle laterally away from the globe. You could divide it into 3 shots. Initially behind the orbital iris, anterior to the equator, and later you give it behind the globe. So this is the technique of giving the superior block. Now, this is the most vascular quadrant. So you need to direct the needle downwards and backwards, and the chances of complications are more. Mostly we do not use this technique. You could also give it between the medial canthus and the caruncle. So the subtenance block is a good balance between infiltration anesthesia and topical anesthesia. First, you numb the conjunctiva with a sponge with a drug, and then use a Westcott scissor and make a small opening in the conjunctiva and the tenens layer, dissect it posteriorly into the retrobulbar space. Remember, the block here enters the retrobulbar space, hence you get good akinesia and anesthesia. So you can use a special Stevens cannula, or you could also use a lacrimal cannula or a 19 gauge cannula if you don't have one. And remember, the fourth nerve here generally doesn't get blocked immediately because it lies outside the cone. And coming to topical anesthesia, now this is wonderful because all the complications like globe perforations, injury to the optic nerve, life-threatening complications if the drug enters the CSF, like cardiorespiratory depression, convulsions, etc., do not occur. Also, there is absence of pain due to injection, so the patient is comfortable if he's apprehensive of it, and there's immediate visual recovery after the surgery. Also, it does not increase the orbital volume like the infiltration anesthesia does. So this can be augmented with topical intracameral lignocaine, preservative-free, or so you must remember that there is no akinesia, hence the patient has to be cooperative, and you must also exercise caution when you are doing a large incision surgery. Pain, remember, is experienced largely when there is stretching of the eyeball. So some complications of infiltration anesthesia, chemosis, ecchymosis. This is retrobulbar hemorrhage, which can compress on the optic nerve and compromise the vascular supply. So how do you identify a retrobulbar hemorrhage? There's painful proptosis, the eye becomes very tense, there's chemosis, decreased visual acuity, etc. So like I said here, it causes ischemia of the optic nerve and retina, and potentially it can result in visual loss. So what prevents the globe from moving forward when the volume within the orbit increases is this eyelid complex. So, you know, when we manage a retrobulbar hemorrhage, we need to do an immediate decompression. So we do a lateral canthotomy and inferior cantholysis. What this does is helps the globe to prolapse anteriorly, thus relieving the pressure within the orbit. So this is an image showing the same. So you can see the lateral canthal tendon, and you crush and cut it. And so it turns a Y into a V, and you can even cut the lower limb if you must. And so this is how you do cut the lower limb of the V. So just very briefly, retrobulbar anesthesia, very little volume, 2 to 4 ml, contrary to 8 ml in peribulbar, immediate onset, but you may need to augment it with a facial block. Risk of complications are higher. Peribulbar takes longer to act, sometimes up to 10 to 20 minutes. You need not augment it with a facial nerve block. The complications are lesser. So having this background, I think you will be more comfortable to decide what block to use. And remember, surgeon's comfort is primary because you want to give a good visual outcome. Also depends on patient demand and comfort, and of course the complexity of the case. So with this, I end my presentation, and I'm very grateful to the society for giving me this opportunity. Thank you.
Thanks a lot, madam. That completely talks everything about anesthesia. Now over to the next presentation. Can you play the next presentation on wound construction? Mr. Karthik?
I'm playing the next presenter.
Yeah.
Mr. Karthik needs to be here. This was an SOS presentation in the middle for me.
Yeah, I think Karthik needs to be here. I think he's probably handling a couple of sessions.
Good evening to all the delegates, and at the outset, I would like to thank the organizing committee of the Karnataka Ophthalmic Society for giving me an opportunity to present on my favorite topic of manual small incision cataract surgery. After a proper block, which could be either a peribulbar or topical, the most important thing in a small incision cataract surgery is the wound construction. So wound construction, today I would like to discuss about a few salient points. Coming to the wound construction, the characteristics of any wound construction is it plays a very major role in SICS. It alters the refractive status of the eye, and it should be planned for each and every case separately, and it decides the success of the case. So scleral incisions have a good healing power, and they are more forgiving. So these incisions can manage the pre-existing astigmatism. So what are the prerequisites for a proper wound construction? First is a good visualization. You need to visualize the area where you are going to put an incision. Globe stability, either in the form of a superior rectus bridal suture or just by holding your limbs at the Tenon's capsule. Then the instrument should be sharp, and the eyeball should be taut. If the eyeball is not hard enough, then there is a chances of buttonholing. Then there should be an adequate scleral incision, which is in the form of a surgical blade, either 50 number or 11 number blade. And next comes the sclerocorneal tunnel, which is done accurately by using a crescent blade. And shape of the incision and site of the incision holds a very important point. And next is the AC entry. Anterior chamber entry is through a correct keratome entry, which goes inside while cuts. It should be always a smile-shaped incision. So incision should be sutureless, self-sealing with a corneal valve action. So there are different parameters of the incision. One is the site or location. Next is the adequate width, then shape of the incision, length or size of the incision, depth, which should be half to 2/3 of the scleral thickness. Then entry into the anterior chamber should be adequate, as discussed earlier. So length of the incision or size depends on the density of the cataract. If the cataract is little harder variety, we can extend the incision up to 6.5 millimeter or 7 millimeter. If it's a soft cataract, we can get away with a 4 to 4.5 millimeter incision. In incision, there are two types. One is the external incision and another is the internal incision. External incision, there is a groove on the sclera and tunnel is made up to the anterior chamber. The internal incision is actually entry into the eye. So both work in harmony to provide, one is the entry port and next is the valve effect. So though many surgeons operate superior temporal or temporal incision is the most commonly formed and it should be done in all cases. Why? Because it has got easy access, distance from periphery to visual axis is more, good exposure. So there is no role of bridal suture, better red reflex. You just push the globe towards the nasal side and have a good retroillumination. It prevents the pooling of blood, better results in terms of astigmatism as most of the patients have against the rule astigmatism. It minimizes the effect of Bell's phenomenon and causes less astigmatism. So what are the effects of incision? Eventual flattening of the surgical meridian is caused by the incision. Longer incision, greater flattening. Closer to corneal apex also causes greater flattening. So what are the structural principles? This astigmatism is directly proportional to the cube of length and inversely to distance from the limbus. Superior scleral incision always induces against the rule astigmatism, which means flattening of the vertical meridian, steepening of the horizontal meridian. Superior temporal or temporal incision induces with the rule astigmatism. So what is the position of the incision? It should be 1.5 to 2 millimeter posterior to the limbus with 3 dimensions. Depth should be 300 to 500 microns. Width should be 3 mm in the center and length anywhere from ranging from 6 to 7 millimeter. So shape or style, many people use different styles like convex. In straight incision, it causes moderate astigmatism, but it's easy to handle hard cataract. Frown is the most commonly used incision, wherein there is only a minimal astigmatism, most easily performed with a soft to moderate cataract. Blue menthol causes very less astigmatism because there is a large incision with the back cuts and it easily engages the nucleus. Least used is the chevron. Though it causes nil astigmatism, it's difficult to construct and needs little practice. The other two are J-shaped and trapezoid, which are not used these days. Smile is avoided because it causes increased astigmatism. So configuration of the wound is very, very important. It should be a triplanar incision. First is the single straight incision. Second is the single corneal oblique stab incision. And third is the single straight incision. Note that the first straight incision and the last straight incision are parallel to the iris. So what are the steps of wound construction? One is the conjunctival peritomy. Next is the sclerocorneal tunneling. And next is the AC entry. So I'll just demonstrate a video wherein these steps are followed. So after the rhexis is done, the conjunctival peritomy is done either with the crescent blade or you can use a 15 number blade. The area is cleanly dissected out and then an incision of 6 to 6.5 millimeter is made. The scleral tunneling is started in the center, going up to the corneal belt, and then the side pockets are made. The side pockets are very important and the internal configuration is of a smile shape, right? Smile shape. And now the anterior chamber is entered with the keratome. And you can see that I'm cutting while going inside. Once this is done, the next of the steps is the hydrodissection, which causes the nucleus to prolapse outside the nuclear bag. And then the nucleus is just dialed into the anterior chamber. And this nucleus can be easily got out of the anterior chamber by sandwich method. And because the wound is very tight and you will have a good tunnel effect. So whenever you want to prolapse something from the anterior chamber, you can just press the posterior lip. Now when you can see that when I'm pressing the posterior lip, all the remnant epinucleus and cortex is just washing out. And the remaining cortex can be easily aspirated by pressing the anterior lip. When the anterior lip is pressed, the AC becomes deep and it helps us to catch a good grip of the cortex. First, the anterior lip of the cortex is caught and then the cortical aspiration is done. So this, you can do it either from the side port or the main wound. Side port incision helps us to remove the subincisional cortex very well. So once this is done, that's, so what I wanted to say is the wound construction is very, very important for the rest of the steps of the surgery. So what are the tips? What I would like to tell is that the crescent plate should be barely visible during tunneling and follow the curvature of the sclera or cornea. Keep crescent tip during scleral tunnel and heel down for corneal tunnel. So my take-home message would be proper wound construction. Choose the best technique in your hands and customize your tunnel. Thank you for your patient hearing, and I would like to take any questions if any. Thank you. Okay. The next presentation is on capsulotomy, can opener to CCC by Dr. Chetan Sadanand. Dr. Chetan is a senior consultant at Chetana Eye Care Center. He's eye volume skilled cataract surgeon and he's got a vast experience on SICS surgeries. Over to his presentation.
Good evening, everybody. I am Dr. Chetan Sadanand from Chetana Eye Care Center, Bangalore, to talk about capsulotomy and capsulotomy. First, I would like to thank Karnataka Ophthalmic Society for giving me a chance to present today. As you can see in the picture, capsulotomy means, tomy means cut. So it is small multiple punctures causing a can opener kind of picture there. Ideally, you have to divide the capsule into 4 quadrants, and each quadrant should have at least 16 micropunctures, which is tangential, connecting to each other. And then with the cystitome, you rip it off and you get a nice circular can opener capsulotomy. Advantages: easy learning access, easy manipulation of the nucleus, and disadvantages are it can run away when you're trying to do multiple capsulotomies, and then disintegration of the IOL. Next, talking about the envelope technique. Envelope, as the name says, it opens like an envelope. A linear cut is given between the nucleus is delivered out, cortical wash is done, and the IOL is inserted, and after which you give the cuts the way it is shown here, and then the capsule is ripped off at around the 6 o'clock position. Again, it is not good for phacoemulsification, but yes, it is a good technique when all other technique fails. Disintegration of IOL again is a big problem in this particular technique. Capsulorhexis, this is a game changer. It meets the demands of advanced cataract and IOL implantation surgery. It can be reproduced by experienced surgeons, and this became a potential for all other developments. It can be done with the needle or with the forceps. The one picture which is being shown here is the one with the needle. There are 2 ways of doing it. One, you have to do it with visco from the side port, or the way I do it, you can enter through the tunnel floor. But there is a difference the way you bend the needle. In case where you want to enter it through the tunnel floor, the end has to be 45 degrees. The cystitome end, and also the superior end also is bent at 45 degrees, whereas in the other scenario, that is while doing through the side port, it has to be 90 degrees both sides. A CCC can be done either by shearing or by ripping. The first picture that which shows it is a shearing technique. Here you start at one point, raise the flap, and then use the force centripetally and start tearing the capsule the way it is shown here. it is better to do it at 4 different spots so that you don't have a runaway rhexis. This has a better control, both with cystotome and with the forceps. This is the ripping technique where you hold it at one edge and then separate the capsule the way it is shown in the picture here. Lesser control, but yes, it can be done in a safe manner. Many people combine both the techniques. It depends on each individual when they are doing the capsulorhexis. This is a picture where the capsulorhexis is being done by entering through the floor of the tunnel. Clarity of the picture is not all that great. First, you raise the flap, and then by shearing technique, you complete the rhexis in the 360 degrees manner. Optional is putting the blue because here the glow is good, but still the surgeons who are starting, it is better that they stay in the capsule. This is the one with the forceps, as said. Through the side port, it has to be done. It cannot be done through the floor entry. So you hold the capsule, raise the flap, and then as the arrow mark is showing, you will have to watch the tearing end and complete the rhexis. Forceps also has a better control in shearing technique. Showing one such procedure here, it is a posterior polar cataract. This is an excellent video by Dr. Shivaji, a friend of mine. I had to borrow this because I hardly use this forceps technique. So raising the flap and slowly tearing off the capsule in a circular manner. When it comes to a posterior polar, it is always better to have a smaller rhexis, maybe 5 millimeter in size. It helps if there is any posterior capsular dehiscence. It helps in the placement of the IOL, either in the sulcus or you can place it in the bag with a haptic capture. There is another way that it can be done. That is under the ACM, anterior chamber maintainer. Dr. Ravi Kulkarni is an expert in this. I borrowed this video from him so that I could show it to people. Here, the flap is raised because it is under ACM. All the fluid is being washed away just by a small depression in the posterior lip, and then you can easily complete the rhexis. Borrowed another video from Dr. Chaitra because this particular technique, he calls it as a spiral capsulorhexis, where you initially raise the flap and slowly start increasing the circumference of the rhexis to the desired effect. This takes a lot of time, but the runaway in this case is very less. If you feel the capsule is coming in the way of the you can always use a Vanas, cut the capsule, and then use the forceps and finish off the rhexis. 14 rules of capsulorhexis. AC chamber should be always and always well maintained. Use high magnification during the operation of the capsulorhexis, at least one. Rest of it, 0.6 is good enough. Look for the red reflex. If you're not seeing the red reflex or it's a matured cataract, it's always better to stay in the capsule with Trefan blue. Use a high molecular weight OVD wherever it is needed. Operate slowly and carefully. Start in the middle with formation of the flap and continue under the tunnel and then on the remaining 360 degrees. Complete rhexis from outside in rather than inside out. Repeat capsular grasping several times, as I already mentioned about it. Keep the opening within the limit of the zonular fibers. A small rhexis is easier to perform than a large one. So it is always better to do a smaller one. And if needed, based on the nuclear size, you can do a second rhexis or give relaxation cuts in case of SICS and then complete the procedure. An irregular rhexis is anytime, any day better than the one which has a tendency to escape to the periphery. Should the smallest sign of escape appear, use OVDs of high molecular weight to reform the chamber. If problems appear, convert to a different technique to reduce complication. Thank you.
Yeah, the next topic is going to be hydro procedures. by Dr. Vasudev Timmaya. He's a senior consultant at Netradeep Eye Hospital, Tumkur. He's a skilled cataract and glaucoma surgeon. So over to the presentation.
Hello, good evening. I thank the organizing committee and Karnataka Ophthalmology Society for giving me this opportunity to present. Today, I will be presenting on hydro procedures in small incision cataract surgery. Hydro procedure is one of the important steps in SICS. Of course, all steps are important. However, if this step is not performed correctly or is not done properly, then the procedure time of SICS will be extended, and it may extend anywhere between 15 to 30 minutes, which may or may not include complications. Basically, hydro procedure has two parts, hydrodissection and hydrodelineation. So let's start with hydrodissection. So what do we mean by hydrodissection? It's essentially the complete dissection of the cortical nuclear mass from the capsule with the mechanical help of a fluid wave produced by injecting BSS or ringer lactate exactly between the anterior capsule and the cortex. So what are the instruments required for this procedure? One, you require a syringe, either 2cc or a 5cc. Some even use a tuberculin syringe. Two, you require a cannula, which is either bent or straight. Bent is usually preferred. The cannula is either rounded or has a rectangular tip. The gauge of the cannula can be 26 gauge or a 30 gauge. So what's the technique? The first thing is, before you do a hydrodissection, you will have to ensure that the extra visco is removed from the anterior chamber. And the technique is very simple. The number of points or sites for doing a hydro can vary. But the most important thing that one should remember is that the hydrodissection has to be done on the same plane always. And the procedure is as follows. Simply lift the capsule gently and inject the BSS solution. In this slide, you can make out the BSS solution going in, gently dissecting the capsule from the cortical nuclear mass, exactly here. So what do we do at our center? What we do is a two-flow technique, 3 o'clock and at 9 o'clock. Ensure that the cannula is sufficiently inside. And then after you've injected the solution, you can see the lens popping out. So what's hydrodelineation? In this, the cortical matter is separated from the nucleus and the epinucleus. As seen in the diagram, the hydrocannula is inserted into the cortical matter and the BSS is then injected. So hydrodelineation is also called hydrodemarcation. In this procedure, the nucleus appears to have a golden ring after the fluid wave passes around. And here you can see in this diagram a clear golden ring around the nucleus. So now the question is, should we do both the procedures in every case, hydrodelineation and hydrodissection? No, not necessary. If you're not a beginner surgeon, a good hydrodissection is all that is required. However, if you have doubts about the hydrodissection, you can go ahead with the hydrodelineation. So is there a role for hydrodelineation? And if so, in which cases it's required? It's required in the posterior polar cataract, required in posterior subcapsular cataract, in traumatic cases where there is a doubt about whether the PC is intact, juvenile pediatric cataracts where there is no hard cataracts. Note about capsular block syndrome. So what's a capsular block syndrome, or entrapment of fluid in the capsular bag? Or simply put, liquid gets caught in the capsular bag. This happens very rarely, but it does happen. What is the possibility for this to happen? When liquid is pushed from only one side and not from multiple sides, this is what can happen. So what do we do when this happens? Gently tap the nucleus to remove the excess fluid. After that, gently rotate the nucleus. If this is missed, there could be difficulty in popping the nucleus, leading to further complications. So what are the preoperative conditions that one must keep in mind while doing hydro procedures? High myopes, post-vitrectomy, traumatic cataracts, pseudoexplanation syndrome, posterior polar cataracts, posterior lenticonus, complicated cataracts, and hypermetric cataracts. You could run into complications if you're not careful while doing hydrodissections in these situations. So let's look at some situations that could be challenging while doing hydrodissections. Now, when you're doing a hydrodissection, two things can happen. One, you can do a complete hydrodissection, then there's no problem. Then there's another one where you do an incomplete hydrodissection and a delineation. If an incomplete hydrodissection is done, then there will be a lot of cortical capsular adhesions leading to difficulty in aspiration and cortical wash. So what is recommended is that if you have a doubt of whether it's incomplete, then repeating the hydrodissections is required, and rotating the nucleus inside the bag is more important to ensure that the nucleus is separated from the capsule. One of the purpose of continued injection of fluid is to increase the hydrostatic pressure within the bag to pop up the nucleus. Trust me, this maneuver is very simple and safe, as a posterior capsule can withstand pressures of up to 59 millimeters of mercury, plus or minus 10 millimeters of mercury. So gentle, confident push is all that is required. So let's look at another situation. What happens if you've done a can opener capsulotomy? In this case, concentrate more on hydrodelineation rather than hydrodissection. Every step has to be calibrated. Using a profound blue helps in noticing where the margins are. If you are a beginner and still learning to do a continuous capsular access, then the number of punctures for the capsulotomy should be in the range of 30 to 40. To ensure that the margins, you can have a look at it, use refined blue. In case of an incomplete capsular access, hydro to be done near the rhexis margin rather than the can opener side. What happens in the presence of zonular dianesis? Some of the predisposing factors for them, as I've listed here: PXF, Morphin syndrome, high myopes, ocular trauma, previous intraocular surgeries. You just need to watch out for one thing: watch out for tilting of the nucleus. In case there is zonular dianesis is noted, using a CTR is recommended. So what are the complications of hydro procedure? One is extension of the capsular tab. Second is rupture of the posterior capsule, which can lead to the deadliest complications, nucleus drop. And one of the reasons being that the posterior polar is the thinnest. If you look at this figure, the posterior polar is around 4 microns compared to the others, where it's 14 and 23 and 17 microns. So what's the take-home message? Critical to the success of all subsequent surgical steps is a hydrodissection. Ensure that the anterior chamber is not filled with Zisco before doing hydrodissection. Proper placing the cannula. Gentle tenting of anterior capsule. Gentle and controlled BSS injection. Absorb fluid wave passing through the cortex and posterior capsule. Gently depress the nucleus. Rotate the nucleus to ensure lens is being completely free. Thank you.
The next presentation would be on nucleus delivery by Dr. Ganeshwar Prasanna. He's a consultant at Globe Eye Foundation. He's a senior surgeon for both cataract and glaucoma. Over to Ganeshwar.
Hello everyone. This is Dr. I thank Dr. Alan Kumaran sir for giving me this opportunity. I thank Chair Dr. M.S. Ravindra sir, Co-Chair Dr. Mallikarjun sir, Moderator Dr. and all the faculty members for agreeing to be the part of this program. Coming to the nucleus delivery, annual cataract. The things that we need to keep in our mind is that for a big incision and a big rhexis, for a big to have pupils and a large rhexis not less than 6 millimeters and an incision size not less than 8 millimeters. A good incision architecture, which is already discussed. The guiding point for the incision size should be the nucleus density, and liberally use viscoelastics, and learn from the videos and from the masters whichever the technique that you're comfortable with, and master the technique constantly, and always be watchful of the structures that you are handling so that you would avoid zonal dialysis, PCR during this step. So if the pupils are not dilated and if the pupils are well dilated, aim for a larger axis. And two things that I need to tell you, there are two obstacles here. Mainly, dilated fluid. Next is iris size and rectus size. Rectus, if it is more than 6 mm, is very ideal. And you can use two techniques here. One is the hydroflap, gentle hydro, and flap one pole of the nucleus outside, and then maneuver it into the ambulation. The other is the bimanual technique shown on the right side of the video. We are using the spatula, just go around the equator by pushing the nucleus into one side and just manually wheel it out of the capsular bag. So in harder cataracts that you cannot do forceful hydroflap, not be done. The bimanual flap technique is very much ideal. The next technique, once the nucleus is in the anterior chamber, it is the that you are taking care where the incision, where to get the nucleus out of the incision. So if it is a very soft cataract, you can plan for a visco expression, injecting the visco distal to the and beneath to the nucleus, and then keep on depressing the posterior lip, and then express the soft nucleus out of the incision. So it can be practiced in softer cataracts, but mindful of the incision size. Always plan for a bigger incision. The second best technique for all types of nuclear sensitive applications, we are using two instruments. One is the rectus, and another is the dialer. To prevent endothelial trauma, we can use the dialer, and the rectus just guides the nucleus out of the incision. This technique can be used for almost all types of cataracts. The alma mater mega system, where I learned this technique, and we should use super rectus here, pull the super rectus forward, and using the irrigating vessel, the hydropressure, depress the posterior lip and take the nucleus out of the incision. Other most is practice where I can depress the posterior lip once the nucleus is in the anterior chamber and inject distally the balance R solution and depress the posterior lip and express the nucleus out. This is also a very good technique, similar to visco expression. Some other techniques are also followed. For the completion sake, I have this technique. If you're interested, you can learn. But of all the techniques that I am comfortable nowadays, the paper sandwich technique, which is very comfortable for me and very safe, because there are two instruments, one is the this and another is the dialer, which prevents endothelial trauma, and that's how we can detect for nucleus of all densities. So well dilated pupil, larger axis, not less than 6 millimeters. Plan for axis more than 6 millimeters. Have incision size thickness more than 8 millimeters. Liberal use of visco, and bimanual prolapse techniques for harder cataracts, and gentle hydro wherever it is required, and drag the nucleus out in intermediate density cataracts. Definitely use bimanual prolapse technique for collapsing the nucleus out of the eye. So nucleus delivery then becomes very much easier. I thank and all for your kind attention.
The next speaker would be Dr. Pradeep Reddy. He will be dealing with cortical wash tips and IOL implantation. Dr. Pradeep Reddy is a consultant at Meenakshi Netralaya, Yadgir. He's a very talented young surgeon and is also our active member of the International Society of Manual Small Incision Cataract Surgery, Karnataka chapter. Over to Dr. Pradeep Reddy.
Good evening, everyone. Cortex aspiration is one of the most crucial step in cataract surgery. I'll be showing the two videos on cortex aspiration and the two videos on IOL implantation. One of the key tips for cortex aspiration is Hydrodissection. A thorough, clean cortical hydrodissection is a crucial step for easy cortex removal. After the lens nucleus removal, irrigate the anterior chamber with Simcoe. This not only helps to clear the visual axis, also loosens up the cortex. Once you are able to see the intraocular structures well, then catch hold of the anterior leaf of the cortex and slowly with the tangential movements pull it towards the center and aspirate. Note that I am just catching the anterior leaf of the capsule and aspirating. A gentle PC polishing being done to remove the small piece of the cortex, and from the side port I am remove the subincisional cortex. This is the second video of cortex aspiration. The anterior chamber being just irrigated and slightly aspirated to see the visual axis clearly. I recommend the beginners to go and aspirate the cortex aspiration from the side port. This not only deepens the anterior chamber and pushes the PC down, it also inflates the bag well and you will be able to catch the cortex easily. And I recommend beginners not to pull the cortex directly into the center because it causes undue stress on the zonals, and sometimes if unknowingly if you catch the anterior rim of the capsule, you can even cause zonular dialysis. Whichever the easy accessible positions of the portions are there, aspirate either from the main port or from the side port. Throughout the cortex aspiration, make sure that anterior chamber is well formed. This can be done by not pushing the posterior lip of the main tunnel downwards. And now subincisional cortex being aspirated from the side port. Now coming to the IOL implantation. IOL implantation can be done in the sulcus or in the bag, but in the bag IOL implantation is the ideal and recommended in all cases. After removal of the cortex, fill the anterior chamber with visco and then hold the mid of the optic with the McPherson's forceps and gently insert the leading haptic into the bag. Fill the anterior chamber with viscoelastics. A dial holding at the optic haptic junction or from the dialing hole, and dial in such a way that the trailing haptic should also be into the bag. This is one more video. Hold the McPherson's at the mid of the optic and gently insert the leading haptic into the anterior chamber and then direct it into the bag by raising the trailing haptic. Then hold the tip of the trailing haptic with McPherson's and gently insert into the bag by slightly pronation. Now dial it properly and also check whether both the haptics are inside the bag. All to confirm that all the haptic is in the bag. These are the few tips of cortex aspiration and IOL implantation. I thank the COSCON organizers, and ISMS team for giving me an opportunity to talk. Thank you all.
Thank you, Dr. Pradeep. With the permission of the chair, for the shortage of time, can we move on to next session, sir? Complications, prevention, and management. I think if there are no questions, we can move on to the next session.